Welcome to the deep dive. Today we're tackling something that sounds quite specific but is actually a major emergency in the equine world. Foal uroperitoneum. Picture this. A newborn foal, just days old, and inside its abdomen, urine is accumulating. It sounds, well, unpleasant, but it's far more serious than that. It's life-threatening. So our mission in this deep dive is to really get under the hood of this condition. What exactly is it? Why is it so dangerous? How do vets even figure it out when the signs can be subtle? And crucially, what are the life-saving steps? We've got a great set of sources here that really map it all out, from Diagnosis right through to Prognosis and even future research.
Yeah, and it's a fascinating condition because it really shows how one localized problem, a leak, can spiral into this huge systemic crisis. It's not just about fluid in the belly. It throws the foal's entire body chemistry completely out of whack, affects pretty much everything.
And we'll uncover some surprising details for you along the way, like how easily those early signs can be missed, or why one specific test is absolutely critical for nailing the diagnosis. So let's dive in. Okay, first things first. Let's unpack the term uroperitoneum. What fundamentally are we talking about here?
Right. So basically, uroperitoneum just means there's urine collecting where it shouldn't be inside the peritoneal space, the abdominal cavity. And it's there because of a leak somewhere in the urinary tract. In foals, the usual suspects are, number one, a tear in the bladder wall, often the top part, the dorsal wall, which tends to be a bit thinner. Or number two, a rupture of the urethus. That's the tube that connects the bladder to the umbilical cord during fetal development. These ruptures often happen because of trauma during birth or maybe an infection around the umbilicus afterwards.
Okay, so a leak. But you said it's much more than just sort of a plumbing issue or a wet belly. What's the tipping point? What makes it so life-threatening?
That's the crux of it. Urine has a very specific composition. It's loaded with potassium, but low in sodium and chloride compared to blood. When that urine spills into the abdomen, the body tries to balance things out across the peritoneal membrane. So potassium floods out of the urine and into the foal's bloodstream, and sodium and chloride move the other way into the abdominal fluid. This creates this classic dangerous triad of electrolyte problems. Severe hyperkalemia, that's the high potassium.
Right.
Hyponatremia, which is low sodium, and hypochloremia, low chloride. And of those three, the hyperkalemia is the big emergency. Extremely high potassium is directly toxic to the heart muscle. It messes up the heart's electrical signals, causing dangerous arrhythmias. You can see things like a really slow heart rate, bradycardia, or electrical blocks, even atrial standstill, or full cardiac arrest. On top of that, the foal develops metabolic acidosis. The blood gets too acidic. And waste products like urea and creatinine build up. That's azotemia. And yeah, the sheer volume of fluid pressing on the diaphragm can make it really hard for the little guy to breathe properly.
So it's a multi-system attack triggered by that initial leak. Given how serious this is, how common are we talking? Who's most at risk?
It's definitely a recognized condition. The reported incidence rates vary a bit, but typically somewhere between, say, 0.2% and 2.5% of neonatal foals. So not incredibly common, but definitely something vets see.
And here's something I found really interesting in the sources. Male foals, colts, seem to be much more likely to get this.
That's absolutely right. It's a significant difference, especially for congenital cases, the ones they're basically born with. Over 80% of those happen in colts, and the anatomy explains it. Colts have a longer urethra, which creates more resistance when they urinate. This can lead to higher pressure inside the bladder, making it more susceptible to tearing, especially during straining or birth.
Interesting.
Now, congenital ureteral defects, problems with the tubes from the kidneys to the bladder, are actually more common in fillies. And acquired uroperitoneum, the kind that develops later, seems to affect both sexes pretty equally.
And the timing. When do owners or vets typically start seeing signs? Is it immediate?
Not usually immediate. Most cases get diagnosed in that first week of life, typically between day 2 and day 5. But, the signs can pop up anywhere from day 1 right up to maybe 60 days old in some cases. Other risk factors? Well, any sick newborn foal that's lying down a lot, prolonged recumbency. Vets might even place a urinary catheter preventatively in those cases. And foals with neonatal maladjustment syndrome, dummy foals, they're also at higher risk, possibly because their bladder muscle tone is altered.
And you mentioned earlier the signs can be subtle at first. What does that progression look like? Often they seem fine at birth.
Exactly. They're often born looking completely normal. But then, over the next 24 to 72 hours after the rupture happens, you start to see this gradual deterioration. The very first signs might just be, they're not nursing as eagerly, seem a bit lethargic, maybe depressed, off their feed, really nonspecific stuff.
Easy to miss or attribute to something else.
Very easy. Then, as more urine accumulates, that abdominal distension starts to become noticeable. The belly looks swollen, and if you gently palpate or tap it, you might feel that distinct fluid wave, like a little water balloon in there.
And what about urination itself? Do they stop or strain?
It varies. Often you'll see them trying to urinate frequently. That's polyuria, but only passing small amounts, which is stranguria, straining. But some might stop urinating altogether, become anuric. And confusingly, some might actually appear to urinate normally, even with a leak inside. One classic sign in colts, though, is scrotal enlargement. The urine can track down and collect in the scrotum.
Okay. And other potential signs, maybe colic or breathing changes.
Yeah, you can see mild to moderate colic signs. The heart rate might go up tachycardia. Respiratory rate often increases to tachypnea, partly because of that fluid pressing on the diaphragm. In really severe cases with significant electrolyte shifts like low sodium, you might even see neurological signs.
And you mentioned owners sometimes mistake the straining for trying to pass meconium.
Yes, that's a very common confusion. Both involve straining, but there's a subtle difference in posture that can help. Foals straining to defecate, like with meconium impaction, tend to arch their back upwards. That's kyphosis. Foals straining to urinate often arch downward, sort of stretching their belly lordosis, but it's subtle.
And complicating things further, a bad meconium impaction could actually cause uroperitoneum.
It absolutely can, by increasing the pressure inside the abdomen. So yeah, differentiating requires more than just observation. Other things that look similar: systemic infections, sepsis, dummy foal syndrome, other kinds of colic, kidney failure, those ureteral defects. The list is pretty long.
Which really underlines why accurate diagnosis is so critical.
Precisely. You need objective diagnostics because the clinical picture can overlap so much.
Okay, so let's walk through that diagnostic process. A vet suspects uroperitoneum based on history and maybe some of the subtle signs. How do they confirm it?
It starts with a really thorough physical exam, piecing together all those clues. The abdominal distension, checking for that fluid wave, noting the depression, checking vital signs, looking for any swelling around the umbilicus or ventral edema. But like we said, especially early on, the physical exam alone might not be enough. So next step is blood work.
The metabolic fingerprint you mentioned?
Exactly. You're looking for that pattern. The really high potassium, low sodium, low chloride. That hyperkalemia is such a red flag for the heart that often an ECG is done right away.
Looking for the specific heart rhythm changes.
Yeah, things like Brad and QRS complexes, tall T waves, classic signs that the potassium is affecting the heart's electrical function.
Yeah.
Blood work will also show the azotemia, high BUN and creatinine, and the metabolic acidosis. And it's standard practice to check IgG levels too, just to assess the foal's immune status, see if they got enough colostrum.
Okay, blood work gives strong clues. But what's the definitive test?
The gold standard is analyzing the fluid from the abdomen itself, abdominocentesis. You carefully insert a needle and draw off some of that peritoneal fluid. Typically, it's a large volume, pale yellow. Sometimes it might smell faintly of urine, hence the informal heat and sniff test some vets use for a quick indication. But the definitive measurement is creatinine. You compare the creatinine level in that abdominal fluid to the creatinine level in the foal's blood serum. If the fluid creatinine is at least double the serum creatinine, that confirms it's urine in the abdomen. Creatinine doesn't cross that peritoneal membrane easily like electrolytes do, so it concentrates in the leaked urine.
Got it. So that creatinine ratio is key. What about imaging? Ultrasound, CT?
Imaging is super important, especially ultrasound. They're really the most reliable imaging method here. Ultrasound will almost always show a large amount of free fluid in the abdomen, like over 90% of cases. And in maybe half the cases, you'll see a collapsed bladder.
Can it actually show the tear itself?
Sometimes, but not reliably. Maybe only in about 18% of cases can you directly see the defect. So, importantly, not seeing the tear on ultrasound doesn't rule out the need for surgery if the other signs fit. Ultrasound is also great for guiding the abdominocentesis, making sure you get a good fluid sample safely. CT scans, specifically CT urography, where they use contrast, can give incredibly detailed pictures. They're especially helpful for rarer problems like ureteral tears or complex cases, but CT requires specialized equipment and isn't available everywhere.
Okay, that's a really clear diagnostic pathway. So diagnosis confirmed, the foal is in a critical state. You said you can't just rush to surgery. What happens first? What's the immediate intervention?
Right, this is absolutely critical. Uroperitoneum is a medical emergency first. The immediate threats are that severe hyperkalemia messing with the heart and the respiratory compromise from all that abdominal fluid. Ignoring these and going straight to surgery significantly increases the risk of anesthetic death. Medical stabilization beforehand is non-negotiable and drastically improves the chances of survival.
So how do you stabilize? What's involved in correcting those dangerous electrolyte levels?
The number one priority is getting that serum potassium down, ideally below 5.5 milli-AQL before anesthesia. It's a multi-step process. First, we give calcium gluconate intravenously. Now, calcium doesn't actually lower the potassium level, but it protects the heart muscle. It raises the threshold for arrhythmias, essentially shielding the heart from the potassium's dangerous effects while you work on lowering the potassium itself. To actually lower the potassium, you use intravenous dextrose. This stimulates the foal's own insulin release, and insulin helps drive potassium from the bloodstream back into the body's cells. And then you administer intravenous fluids that are low in potassium. The go-to is usually 0.9% sterile saline. This helps dilute the potassium in the blood and encourages the kidneys to excrete it. Sometimes diuretics are used cautiously too.
What about sodium bicarbonate? I've heard that mentioned for hyperkalemia.
It used to be used more, but it's generally not recommended now for this specific situation. Saline and dextrose are the mainstays, and careful fluid rate calculations are essential to avoid overloading their circulation.
Makes sense. And what about physically removing the urine that's already leaked? Does draining the abdomen help?
Absolutely. Draining the abdominal fluid has two huge benefits. One, you're physically removing a large reservoir of potassium, which directly helps lower the systemic level. Two, you're relieving that pressure on the diaphragm, which can dramatically improve the foal's breathing and comfort. At the same time, placing an indwelling urinary catheter is also really important. This keeps the bladder empty, which reduces tension on the bladder wall, prevents further leakage, and can help tiny tears start to heal.
So catheterization and drainage. Could that sometimes be enough on its own without surgery?
That's a really interesting point. For very small bladder tears, yes, sometimes this combination of abdominal drainage and continuous urinary catheterization, along with aggressive medical management, can actually allow the defect to heal on its own, conservatively.
Fascinating.
But it requires careful monitoring. And regardless of whether surgery is immediate or potentially delayed, broad-spectrum antibiotics are crucial from the start. These foals are incredibly susceptible to infection and sepsis.
Right. So assuming the foal is stabilized and conservative management isn't the route, surgery is the next step. What are the surgical options for repairing the leak?
There are basically two main ways to go. The traditional approach is a laparotomy, usually a ventral midline incision, opening the abdomen fully. This gives the surgeon direct, wide-open access to find the tear and repair it thoroughly. It's effective, but it's more invasive, bigger incision, potentially longer recovery.
And the alternative?
The alternative is laparoscopic surgery or keyhole surgery, using small incisions, a camera, and specialized instruments. This is minimally invasive. Advantages can include less pain, maybe faster recovery, and the magnification from the camera can actually provide excellent visualization of the tissues.
But it requires specialized training and equipment.
Definitely. Not every clinic can offer laparoscopy.
Okay, so whether it's open or laparoscopic, what's involved in the actual repair? How do they fix the hole?
First, they need to find it accurately. Sometimes they'll distend the bladder with sterile saline, maybe mixed with a dye like fluorescein, which makes the leak obvious. Once located, the tear is typically closed using a specific suture pattern, usually a double-layer inverting pattern. This turns the edges of the tear inwards, away from the bladder lumen, to create a good seal, often oversewn a couple of times for extra security.
And the type of suture material matters, right?
Hugely important for long-term outcome. The recommendation now is to use absorbable monofilament suture material. Why? Because things like multifilament braided sutures, or non-absorbable ones, or even surgical staples, have a much higher risk of acting as a nidus, a starting point for bladder stones calculus formation later on.
Ah, okay. So the monofilament reduces that complication risk?
Exactly. It's a critical detail. And for those rarer urachal or ureteral defects, the surgery can be more complex, might need those advanced CT scans beforehand, and potentially more specialized procedures like removing a kidney or reimplanting a ureter.
It sounds like a very delicate repair process. So surgery's done, the leak is fixed, but recovery isn't guaranteed, right? What does post-op care involve, and what are the bumps in the road?
Post-op care is intensive. That urinary catheter usually stays in place for at least 72 hours after surgery.
To keep the bladder decompressed while it heals.
Precisely. Reduces tension on the suture line. Systemic antibiotics are continued, usually for several days. And close monitoring is key, checking for any signs of leakage, fever, monitoring their attitude, appetite, urine output. Regular follow-up ultrasounds are often recommended too, because sometimes recurrent signs can be delayed.
Recurrence is a possibility then. How common is that?
It does happen. Estimates range from about 12% up to maybe 27% of cases. It's often due to the sutures breaking down, or maybe the closure wasn't quite perfect. And here's a crucial link. Sepsis, that systemic infection, is a major risk factor for the repair failing and the uroperitoneum recurring.
So controlling infection is paramount. What other complications can arise?
Adhesions are another concern. That's internal scar tissue forming between abdominal organs. While many foals, especially those without sepsis, don't develop significant adhesions in severe cases or those complicated by infection, adhesions can form and potentially cause chronic colic issues down the line, sometimes severe enough to warrant euthanasia, unfortunately.
And sepsis itself remains a threat even after surgery.
Absolutely. If a foal develops sepsis concurrently or postoperatively, the survival chances drop significantly, maybe down to only 57% or so in septic foals. So alongside the specific treatments, excellent supportive nursing care is vital, keeping them clean to prevent urine scald, managing pain with NSAIDs or opioids, continuing fluids as needed. It's a team effort.
It really sounds like it. So putting it all together, what's the long-term picture for these foals? What factors determine their ultimate prognosis?
Well, it's definitely multifactorial. But two things really stand out from the research as being critical for a good outcome. One, successful early medical stabilization, especially getting that potassium level down before surgery. Two, the absence of other major problems, particularly sepsis. If you could achieve those, the prognosis is generally pretty good.
And timeliness matters too, presumably.
Hugely. The quicker the diagnosis and intervention, the better. For standard bladder or urethral ruptures that are treated promptly and successfully stabilized, survival rates are generally good. Around 80% make it. Those rarer urethral tears, though, tend to carry a poor prognosis.
What about overall survival statistics?
Short-term survival, meaning they make it out of the hospital, is typically reported somewhere between 56% and 86%. Long-term survival, looking at 6 months or more, is often around the 69% mark.
And comparing surgery versus trying conservative management.
Surgery offers the most definitive fix, usually with a rapid and complete recovery if all goes well. Conservative management can work for carefully selected cases with very small tears, but there's that ongoing risk of complications like adhesions developing later. So patient selection is absolutely key if you're considering the non-surgical route.
Okay, looking forward now, where is research focused in this area? What are the next frontiers?
There's ongoing work to refine diagnostics, making ultrasound even better at potentially visualizing the tears themselves and exploring the broader use of CT urography, especially for those complex or unusual cases. On the treatment side, there's a lot of interest in minimally invasive surgery laparoscopy. We need more long-term data comparing it directly to traditional open surgery. Researchers are also looking at new suture materials or techniques, like barbed sutures perhaps, to further reduce those complications like stone formation.
And preventing complications seems like a big focus too.
Definitely. Finding better ways to prevent abdominal adhesions is a major goal, and really digging deeper into that complex relationship between sepsis and surgical failure or recurrence. Anything to improve the overall outcome and welfare for these foals.
So wrapping this up, what's the main takeaway for our listeners, whether they're directly involved with horses or just fascinated by this kind of veterinary challenge?
I think the absolute core message is that foal uroperitoneum is a critical emergency, where prompt medical stabilization is just as important, if not more so initially, than the surgery itself. Recognizing and rapidly correcting that severe hyperkalemia is truly life-saving. Without addressing the metabolic chaos first, the surgery alone might not be enough.
It's a powerful reminder of how interconnected everything is in the body. This deep dive really highlights that incredible balance of complex systems, how a single, seemingly small anatomical flaw, a tiny tear, can trigger this cascade, this full-body crisis. Makes you wonder, doesn't it? What other systems, maybe in animals or even in us, are just as delicately balanced, where one little disruption can have such far-reaching consequences? Something to think about.